Okay, Peter, Richard, you're two academic cardiologists, and we've been through a day and a half of fantastic lectures about, inflammation, cardiovascular disease, diabetes, pathophysiology of diabetes. Peter, on your side, what's your take-home message regarding this whole issue of inflammation and CVD?
Well, we're in a very exciting time in thinking about inflammation and cardiometabolic risk because it's taking root in the clinic. We've been interested in this from the perspective of basic science in the laboratory and all of our mouse experiments for years. And it's a very exciting time because we're now seeing the issue of inflammation really take wings in practical clinical terms. For example, we now know that we can predict risk in broad different categories of patients and individuals who aren't even esteemed as being at risk on usual metrics using inflammatory biomarkers such as high sensitivity CRP. We know that we can target therapy such as statin therapy that ordinarily wouldn't be given to people who have higher levels of hsCRP and prevent events. And we heard at this meeting some very exciting data about how in people whose diabetes is not perfectly well controlled, that adding an anti-inflammatory agent in pilot studies can actually improve biomarkers that correlate with clinical outcomes. So that's really the excitement. We had wonderful talks about the basic science of inflammation, but the real excitement for me as a practicing cardiologist is the clinical application seems to be within grasp.
Dick, on your side, I guess also I've heard you before mentioning that the mosaic of modifiable risk factors is evolving. You see more and more now among your patients these mid-30 gentlemen with who are abdominal obese and showing this inflammation among other features that Peter has described.
Well, I think the value of this meeting is that we're trying to go away from looking at patients as either having hyperglycemia or diabetes or having high cholesterol. That we're really looking at the phenotype of the patient in the office and seeing how we can use that information to lower cardiovascular risk. And as Peter Libby said, the whole notion that this complex metabolic state leads to inflammation and some opportunities for some novel therapies. And salicilate's already been mentioned. Who knows what's around the corner? These patients still have substantial risk, even when we correct all the known risk factors that they have. And so I think the meeting today was very important because we learned a lot about the mechanisms that may underlie not only developing diabetes, but that link to cardiovascular disease. What you said is absolutely correct. I am very fearful that in the next 10 or 20 years, we will see a greater relative percent of patients with heart attacks appearing in that 30 to 50 age group because of not only the increasing prevalence of type 2 diabetes, but its occurrence at a much earlier age. And so I think we have a lot of people now incubating very premature cardiovascular disease that we may not have had several decades ago.
It was also almost, I feel dizzy when I heard the many possibilities leading to insulin resistance from an insulin signaling standpoint. The options are numerous, and also our quest for genetic markers of susceptibility to type 2 diabetes. This is very difficult. It's a daunting task. But in terms of lifestyle modification, we also heard that the low-fat message in terms of recommendation to a patient population could have been quite misleading. I'd like you to react to what we heard today.
Well, for one thing, the general public embraced this concept of low fat and thought that things that were labeled low fat in the supermarket were health foods. And in fact, a lot of those commercially produced products that were labeled low fat are very high in calories, very high in carbohydrates, and could have actually contributed to some of the current problem with the obesity epidemic. That's a hypothesis of Gary Taubes. I don't agree with everything that Mr. Taubes has written, but I think that there is certainly a grain of truth in that, and I'd be interested in Dick's comment on that.
Well, I think the public has unfortunately been not misled, but confused by even the recommendations of professional societies. As Peter said, low-fat diets are supposed to be good, but now we know it depends what type of fats, how we replace low fat with what other constituents in our diet. I think one of the messages that I think was important today that I could take away from this meeting is that exercise is a very powerful modulator of risk. It's also something that neither doctors nor patients argue about. There's been no mixed messages about the value of exercise since Hippocrates. But I think most patients, unfortunately, link exercise to weight loss. And if they don't lose weight in any prescription that a doctor has ordered, they tend to stop exercising. So I encourage patients to continue to exercise, even if they gain weight. Some of the weight gain actually may be from the medicines we prescribe for diabetes, and that there is a cardiovascular benefit and a diabetes control benefit associated with continuing exercise, even if they're disappointed about the fact they haven't lost weight.
You know, a lot of our patients, when we say the word exercise, it conjures up immediately a notion of someone who's sweating with a headband wearing spandex, and they get an aversive reaction. And so one way to frame it with our patients is to say that they should engage in regular physical activity and give them some concrete examples, like if instead of waiting for the elevator, it's just one flight of stairs, take the flight of stairs. And we also, I think, have to emphasize that realistic and achievable and sustainable goals in terms of exercise or even modest weight loss can really improve the cardiometabolic profile and are associated with reductions in events. So I think that the way in which we frame this issue of physical activity with our patients is very important.
I guess because of one of the objective of the chair is this clarification on the link between diabetes and cardiovascular disease, that we all recognize the added value of actually reshaping the nutritional habit, and as you pointed out, Dick, bringing physical activity in, even if glycemic control is not that substantially improved, because you have both provided evidence through the years that there's way much more than glycemic control as a driver of the risk of cardiovascular disease in patients with type 2 diabetes, and that in that context, reshaping nutritional habits and physically active lifestyle could have important impact on global risk, irrespective of the sometimes disappointing impact on glucose control, right?
Yeah, well, you know, it's funny when you look at cardiac rehab, which has been around for many decades. It's been a lot of work on what is the real value of cardiac rehab. Some of it maybe its anti-inflammatory effects, it lowers CRP. Maybe most of the benefit is on the value of exercise itself, not so much sort of the aerobic markers that we used to push patients to, this idea that fitness was the endpoint. Well, really, fitness is an endpoint that gets us to a better metabolic state for patients. And so even cardiac rehab retooled is, we actually at Lay Clinic call it metabolic rehab now when our patients go to cardiac rehab, and patients seem to have a better understanding. What do you mean by that? What are you trying to do? And they get their sort of first lesson on what the value of exercise is. It has metabolic endpoints, not so much a heart rate and blood pressure endpoint.
So even though it is a very complicated field, this whole issue of the pathophysiology of insulin resistance, now the complex molecular mechanism linking inflammation and cardiovascular disease, I guess there are still some very simple take-home message: eat healthy and be physically active, and through mechanism others than reducing your blood sugar, you might have a positive impact on the risk of cardiovascular disease. Thank you, gentlemen.
Thank you.